Okay. I hope we can start the rest of the lecture after a small break. So case number 4, a 46-year-old male presenting with an itchy skin rash on legs. And I think the diagnosis is obvious. It's a chronic eczema. Little bit of on eczema. So eczema could be either endogenous or exogenous. Endogenous causes are the atopic dermatitis, which is usually like seen in small children. It starts around the age of 3 to 4 months, and then it tends to wear off when the children get older. And discoid eczemas are the ones which are of round shape, also known as eczema. Then you have the hand eczema. Seborrheic dermatitis is one which is commonly associated with like what we know is dandruff. And then the venous eczema associated with the venous disease, and then the steatotic eczema, usually seen in people with extremely dry skin and elderly. Then we have the exogenous eczemas. These are the eczemas with the external cause. The most common thing is the contact dermatitis. This could be either irritant contact dermatitis or allergic contact dermatitis. Irritant contact dermatitis usually occurs either due to like water, solvent, and any alkali materials. And allergic contact dermatitis is the one which is occurring with repeated exposures like due to hair dye, rubber, cement, nickel, and so on. And then we have the photodermatitis, that is the eczema which is being exacerbated by sunlight. And then the lichen simplex chronicus, which is eczema which is being worsened by chronic itching. Actually, the previous picture that we saw is an example of lichen simplex chronicus. So the clinical features of eczema would vary depending on the stage of the eczema. In acute stage, you can see vesicles, bullous, exudate, and crusting. And in subacute stage, there can be erythema, dryness, scaling, and the lesions can be edematous or crusted. And then in the chronic stage, the skin is extremely dry with thickening and lichenification. So principles of management of eczema. Actually, it's not difficult. So if the skin is dry, you have to wet it. If it is wet, you have to dry it. So if we do this thing, I think like most of the, like about 80% of the eczemas will resolve only with this small principle. So if wet, what are we going to do? We have to dry it with the usage of astringents like potassium permanganate. If dry, we have to use plenty of emollients. Then the other treatment of eczemas like topical, we use topical steroids, calcineurin inhibitors, and keratolytics if the skin is very dry. And then the oral ones like antihistamines for the symptoms of relieve the symptoms of itching, and steroids. And oral steroids should be given only for acute flare-ups and only for a short duration of period. And then if the eczema is chronic and recurrent, sorry, we have to go for the steroid sparing agents. Mistake number 1, using too much steroids. So as we know, there are many different classes of steroids which are depending according to the potency. And then we have to know which steroid to be used and in which quantity. Useful guide for this quantities required is given from this fingertip unit. So if you get a cream to cover your distal phalanx, that is equal to 1 fingertip unit. And 1 FTU can cover the region of hand or groin, and 2 will be enough for a face or foot, and likewise. But this is not the only factor when we know we have to prescribe steroids, because there are many other variants. The safe maximum limit will vary on depending on the strength of the steroid. Like clobetasol, like it's a potent steroid, is recommended for the areas of thick skin like palms and soles. And hydrocortisone is recommended for the use of the face and also in children. Age of the patient is important, and also the site of inflammation, what I mentioned earlier. And when there's inflammation present, there will be increased absorption. So we have to take that to mind as well as the length of the treatment. So these are the side effects of topical steroids. So you can see that there are an acneiform eruption in the trunk. And of course, here again, the steroid has been given for a tinea infection. That's a wrong practice. Then we can see this hypopigmentation, like this is again a side effect of steroids. And this, of course, is being this side effect of topical steroid is usually misused by the people. Actually, it is not by the medical officers, but by salons and other quacks, because they tend to have this. This is an example of a patient who has taken a skin whitening cream to the armpits to reduce the armpit darkening, and she had ended up with this ugly looking striae. So this is again another side effect of steroids. So this side effect of hyperpigmentation in steroid is being used to prepare ointments and creams which are being marketed as skin whitening agents. And then other side effects like perioral dermatitis. This is like a monomorphic papular eruption which is occurring around the mouth area. This is actually a difficult to treat condition because these people are very much dependent on steroids. So even if we diagnose that, we have to reduce the potency of steroid from time to time. And then you see this hypertrichosis, that is increased vellus hair as a side effect of steroids. Then steroid can cause skin atrophy, skin thinning, and you can see these telangiectatic vessels, and also diffuse erythema of the face. So these are all indications of topical steroids. And the mistake number 2 is not detecting secondary infections. So people with eczema are more prone to get infections. So it could be either bacterial infections like impetigo. I think the diagnosis in impetigo is fairly straightforward. You can see this golden yellow crusting. And then the other one is the viral infection, eczema herpeticum. So this is something actually that can be missed because this is like not that common, and unless you are aware of it, this can be missed. So this is like HSV infection which is appearing in a widespread manner in patients with pre-existing skin conditions. So people with eczema are more prone to this. So, sorry. So if the skin condition is worsening suddenly, you have to observe them closely to see whether there are any monomorphic blisters and monomorphic ulcers like this. And if it is there, it is a HSV infection, which usually needs IV acyclovir. So then we will move on to the next case. Actually, this one I have included because it's not because it is common, but because of the importance. So it's a 38-year-old male presenting with well-defined hypopigmented patch, which is slightly palpable, and there's sensory loss to the touch. So I think when I say all these features, you can diagnose it is a leprosy of tuberculoid leprosy. So what is the mistake? Believing that leprosy is normal. I think most of the medical students and even specialists from other specialists think that leprosy is not existing. Yes, we have achieved our WHO elimination targets way back in 1995. But still we see about 2,000 new cases per year. So that is a lot. And also there's a 10% of child leprosy rate. So leprosy is a disease which has a long incubation period. Therefore, if we see a 10% rate of child leprosy in Sri Lanka, that means that's still ongoing disease. So leprosy is here with us. So we have to suspect it to diagnose. So when you take leprosy, actually it is a clinical spectrum. So when the cell-mediated immunity is high, people will develop only 1 or 2 lesions, like it will be just hypopigmented anesthetic patches. And once the cell-mediated immunity is going down, they go to the lepromatous spot. So this is a polar tuberculoid leprosy with a well-defined hypopigmented anesthetic patch, and it can also involve the nerves, and the nerves will be thickened and sometimes can even be visible like this. Then you have the borderline tuberculoid where the patches will become like a plaque. These are palpable, erythematous or copper colored. Still there can be sensory loss over the lesions. Then you have the mid-borderline lesions. These are two characteristic mid-borderline lesions. One, you can see the satellite lesion here. So satellite lesions are characteristic of mid-borderline lesions. And then the other one is this inverted saucer-like lesions. These are again two borderline lesions, mid-borderline lesions. Then you have the lepromatous fold where there will be numerous skin lesions, bilateral and symmetrical. So this is borderline lepromatous where there are like multiple plaques, and then you have the full-blown lepromatous leprosy with multiple nodules with yellow infiltrations. So when it comes to the lepromatous fold, these lesions are not anesthetic, but they will have apart from these skin lesions, they may have glove and Stuckling type of peripheral neuropathy. So mistake number 2 is very important, not detecting nerve damage. So nerve damage in leprosy can occur due to 2 reasons. One is acute, that is due to the reactions. I will be talking about reactions later. And then the chronic nerve damage due to the disease process. So why it is important, the acute nerve damage is reversible. Like if you detect it early and promptly treat it with the sufficient amount of oral steroids, that will prevent or even reverse the nerve damage, and thereby it can prevent the disabilities. Because leprosy is a curable disease, but if the patients develop the nerve damage and then the disabilities, then the patient's life is going to be miserable. So nerve damage in leprosy can involve the eyes, because of the facial nerve involvement. This is again a highly neglected area because leprosy and blindness. So because of that facial nerve involvement, people will end up with difficulty in closing the eye, and that will lead to corneal dryness, ulceration, and even to blindness. Then hands. Acutely, it can involve the the ulnar nerve and cause small muscle weakening of the hands. 1 second. This is battery very low. Yeah, and then they can also develop these deformities like claw hand and then later trophic ulcers. So when it occurs in the foot, acute foot drop, like due to the involvement of the common peroneal nerve, they can develop foot drop, and then peripheral neuropathy can lead to this trophic ulcers. So it could be quite debilitating. Then the mistake number 3 is not recognizing lepra reactions. So what are lepra reactions? Leprosy reactions may occur before the diagnosis of leprosy, when treatment is started, or even later on. So that is why the patients will come to you first, not to a dermatology clinic, because they will just first come with the reactions of the leprosy, and later on only it will be diagnosed. And also, even if the patient is already on leprosy treatment, because of the stigma associated with that, people tend to hide about their leprosy diagnosis. So they will just come with these symptoms to a primary care physician, and they may not reveal the diagnosis of leprosy unless you suspect leprosy reactions and ask about it. So there are 2 types of lepra reactions. One is type 1 lepra reactions that occurs due to heightened cell-mediated immunity, and there will be inflammation of the existing skin lesions. So sometimes people may have this hypopigmented patch for years, and when they are undergoing a leprosy reaction, this becomes more erythematous, edematous, and painful. Then only they will seek medical advice. And also because these reactions can involve the nerves, there can be nerve tenderness, nerve abscesses sometimes, and even acute nerve injuries leading to muscle weakness. So these are two examples of type 1 lepra reactions. And type 1 lepra reactions are usually common in tuberculoid form of leprosy and sometimes and mid-borderline lesions. So this is a nerve abscess involving the ulnar nerve. So the management of lepra reactions is oral steroids. This may prevent or reverse the acute nerve injury if given early. And also, even if you have a lepra reaction, the leprosy treatment should not be discontinued. That is common for both type 1 and type 2 reactions. Type 2 lepra reactions. This is due to the type 3 hypersensitivity reactions due to antigen-antibody complexes depositing in the vessel's walls. So it is a multi-system disorder. So there's more chance that people will not come to the dermatology unit but go to other places. So because of the systemic symptoms, they will have fever, joint pains, myalgia, and sometimes like this multiple, and also in the skin, they will of course have this multiple tender subcutaneous nodules. Sometimes these nodules may not be that obvious. People may not tell about those, like they will not come up with that unless you palpate and see. And biochemically, they will have high ESR and neutrophil leukocytosis, so they can easily be misdiagnosed as any other many common conditions, and they are there's a tendency for recurrence of these reactions. So these are two examples, like erythematous nodules. Actually, we don't see the erythema in our type of skin, and when the reaction is severe, they tend to ulcerate. So these are actually ulcerating leprosy nodules. Here again, the treatment is steroids sometimes, and type 2 lepra reactions are usually seen in lepromatous leprosy pole, and these tend to recur and they need oral steroids and steroid sparing drugs, and this is an indication where oral thalidomide is indicated in recurrent lepra reactions, type 2 lepra reactions. So now we have come to the last one, again a very common presentation. A 36-year-old lady presenting with erythematous papules, pigmented macules, and scars for many, many years. And she's also having irregular menstrual cycle. So the diagnosis, I think it is obvious. It is a moderately severe acne vulgaris. And the hormonal profile and ultrasound scan is suggestive of associated polycystic ovarian disease. So what happens in acne? So acne is actually a disease of the sebaceous gland. So there are 4 pathophysiological mechanisms. One thing is seborrhea, like there will be increased activity of the sebaceous gland. And then there are abnormalities of ductal hyperconfiguration, like the openings of these ducts will not, like the cell degenerating process in these ducts will not happen in the usual manner, and they can get blocked. And this forms a nice environment for the pre-acne colonization and proliferation. Therefore, that will bring about the inflammation. So actually, when we talk about the acne medication, we have to attack these pathophysiological processes. So when we take all the acne medications, it's only oral isotretinoin that will attack all 4, but then there are many other drugs which will deal with at least 1 or 2 of these pathophysiological mechanisms of acne. So again, acne, there are grading, like it could be mild, that is usually comedones, like this could be either closed or open comedones, commonly known as blackheads and whiteheads. And then moderate acne, where there is inflammation and pre-acne colonization. There you can see the papules and pustules. And then you have the severe ones with nodules and even cysts. So when the acne is healing, like if it is moderate or severe acne, there is a tendency for scarring. Acne treatment. So acne is very common, and like treatment again, like we have to treat them according to the staging of the disease. So if it is a mild, like when we take topical retinoid, that is like the baseline treatment of acne, and it has to be given in all cases of acne. And if it is a mild acne, you can either just treat with a topical retinoid, and sometimes we might have to add a benzoyl peroxide. And if it is papulopustular acne, moderate acne, then there will be a place of either topical or sometimes if it is severe, oral antibiotics. And then there are other treatments like azelaic acid and anti-androgens, depending on the associated factors. Like if there's a tendency towards hormonal acne, then we have the oral anti-androgens like spironolactone and cyproterone acetate. So I have not included severe acne because that is an indication for oral isotretinoin, and oral isotretinoin, because of the teratogenicity effect, it can only be prescribed by dermatologist. So mistake number one is not giving proper instructions to the patients. So acne is actually like, now people will expect miracles. They expect they will just come about 1 or 2 weeks before their wedding and try to get their acne cured. So we have to properly instruct the patient about when to expect results. Usually acne medication takes time. It usually takes at least 1 month to start showing some improvement. So this message has to go on to the patient, otherwise they will just end up with another doctor. And also like how to apply these medications, like sometimes especially benzoyl peroxide can cause skin irritation. Therefore, short contact time is recommended in patients with sensitive skin. So if not these advice is given, they will say that the patient developed the side effects to a drug, and then again they will go doctor shopping. And also the other important thing is the follow-up, because acne medication is a continuous process. It has to go on like for at least for 4 to 6 months. So they have to be educated that they have to continue the medicine for the specified period and come back for follow-up, unless they will just end up with a recurrence. Then mistake number 2, giving antibiotics for a prolonged period. What can happen if we give antibiotics for prolonged periods in acne? One is, as you know, is antibiotic resistance. So what are the antibiotics that are commonly available for the usage of acne? One is erythromycin, actually then doxycycline. So antibiotic resistance for both these agents are now known. And then we have azithromycin was given for some time, but then again now the evidence says that it has to be preserved for respiratory tract infections. So it's recommended to be used in acne unless other drugs cannot be given. Then sometimes there are minocycline and cotrimoxazole can also be given as a oral antibiotic therapy in acne, but resistance to all these agents are reported. Then another problem. This is a 28-year-old lady suffering from acne for many years, presenting with this recent worsening of her condition. And she has been previously treated with many months of oral antibiotics as tetracycline, doxycycline, azithromycin, and even coamoxicillin. So what is the diagnosis? This is a gram-negative folliculitis. This happens due to prolonged usage of antibiotics. The gram-positive flora in the skin can be replaced with gram-negative bacteria, and these patients will present with acute onset florid pustular eruption. So you have to suspect this if the acne is not responding to prolonged antibiotics, and if the pustular eruptions are more than papules and nodules. And the treatment for this is oral isotretinoin together with antibiotics covering the gram-negative bacteria. And you can see very good improvement with the usage of oral isotretinoin. So the recommendation for oral antibiotics is antibiotic monotherapy should never be used. I repeat, never. At least it has to be combined with the topical benzoyl peroxide. Even if you give a topical antibiotic monotherapy is commonly being practiced, it has to be combined with the topical benzoyl peroxide to reduce the resistance, and also to limit the usage of oral antibiotics to a maximum period of 12 weeks. Actually, some time back when we were trainees, we used to give like antibiotics for like if it is acne, low dose antibiotics were recommended even for 6 months to 1 year, but now they have cut down the period maximum 12 weeks, and actually we tend to give it only for 8 weeks. So mistake number 3, giving topical steroids for acne. I would say this is not so common as we see the topical steroid usage in dermatophytosis, but this can result in detrimental outcomes like this with severe florid, pustular and nodular eruptions of acne by the usage of topical steroids. And then mistake number 4 is not doing timely referral. Why I'm saying this is acne is a disease with complications. And once you have acne in the childhood, sometimes people can have that misery lifelong with scars. And also post-inflammatory hyperpigmentation can occur in our type of Asian skin. But this is a transient phenomenon, and psychological damage of acne is also well documented. Actually, out of these things, I would say scars is the most problematic thing because it is permanent and it is preventable. So post-inflammatory hyperpigmentation, this tends to go away with time with treatments, topical or sometimes treatments like chemical peeling. But as I said earlier, like scars could be permanent. And there are multiple types of, there are different types of acne scars. And in each patient, you can get, one can get different types of scars. It can be atrophic scars like this, and sometimes hypertrophic scars and keloids like the chest of this young boy. So this is a thing that is preventable. So scars are permanent, as I said earlier, and scar management is lengthy, and and also we can't just get rid of the scars. That will only reduce the depth of the scars. So as you see in these pictures, you can reduce the depth of the scars with various treatments like carbon dioxide laser, chemical peeling, and then microabrasions. But all these treatments are lengthy and time consuming and maybe even expensive. So these are scar management. And what I said earlier is why we have to treat them early is that early proper management of acne will prevent the scarring. So actually, if we are doing a proper job at the primary care physician level, the scars can be prevented. So when to refer acne, like severe acne, mild moderate acne which is not responding, acne with other features of hormonal imbalance, evidence of scarring, and psychological distress irrespective of physical signs. So in summary, I think skin problems are very common, and it can cause significant psychological impact to the sufferer. And correct diagnosis and understanding the severity is important for effective management. And unlike in other conditions, you have all the time to use yourself to refer and may even diagnose later. Thank you. Yeah. Yeah, there are a few questions. So what are the oral antifungals which can be prescribed in pregnancy? So actually at the moment, if it is really indicated, oral terbinafine can be given from the second trimester on, could be given in second trimester onwards if it is really indicated. Should tinea alba be treated? Yes, tinea alba is it is another name. It could be a part of atopic dermatitis as well. It is not dermatophytosis. So this is being used treated with topical steroids. Yeah, so one has asked for differential diagnosis of hypopigmented macules on face in children especially. So there could be like when we take, actually it's a vast number of differential diagnosis would come into place. So one thing would be commonly seen in children would be atopic eczema, and then like photodermatitis if it is on the sun exposed areas, and sometimes it could be early vitiligo, and even P. versicolor. So, and even leprosy will come into the differential diagnosis of hypopigmented patches in now. Just because I talk about leprosy, when leprosy occurs on the face, the sensory loss may not be that obvious in the early stages because the face is having a rich supply of facial innervation.
They are asking what are the effective treatments of foot cracks?
Foot cracks.
Foot cracks.
Yeah, the effective treatment for foot cracks is it happens due to skin drying, so plenty of emollients. And sometimes like you can add humectants like urea for that. So urea combination creams would be very effective and also cheap when compared to other foot cracking creams, crack heels and balms available in the market.